Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of September 25th, 2023. After a COVID status update, I'll discuss available evidence on the effects of COVID vaccine on long COVID. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there is still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look first at wastewater, this graph shows the percentage of sites across the country that have increasing or decreasing levels of SARS-CoV-2. And looking over to the right, just before you get to that shaded gray area, we can see a increase in the percentage of sites that are having increases. So that is the red and the orange. Pretty much from late August through September 6th. That's the most updated data we have there. So that's a few weeks old already. The incomplete data in the gray does look to be trending down, but that's incomplete data. So we won't know for a couple of weeks what's really happening there. And again, this is looking at the whole nation, which obviously has a lot of variability. So if you want to find out what's going on near you, you'll need to find the sewer shed closest to you. For example, looking right here in Oakland, we can see that our wastewater site is updated through September 21st. So that is pretty good, just a few days old. This is from the Verily site. It's linked in the post where I've also linked 5 other different wastewater sites. And despite some zigzagging here, it does seem to be coming down. So let's hope it continues to go that way. We are also seeing a very slight uptick in RSV and influenza A, subtle, but it's there. And I think it's safe to assume that we are likely at the early part of our respiratory virus season. So we will just see how quickly everything ramps up. Now, taking a look at percent positivity, this has finally turned down ever so slightly. It's now at 14.1%, down from 14.3. Also, the number of tests being done continues to go up. So that 14.1% positivity was on about 66,000 tests for the week ending September 9th. As a reminder, in early June, we were just above 4%, so we're more than triple that at this point. So definitely still high. And our most updated indicator, percentage of all emergency department visits with diagnosed COVID-19 in the US. This data is updated through September 22nd. So just a few days old. So I really like seeing this coming down like this, basically for all of the month of September so far, after reaching a peak there at the end of August. And what we want to see is this continuing to come down. And also we want to see this followed by a decrease in hospitalizations and deaths. And we finally do see a very slight decrease the week ending September 16th in hospitalizations. So very cautiously optimistic here. But there were 19,674 hospital admissions the week ending September 16th. This is more than triple what we were seeing for most of the month of June. So definitely still too high. And again, here you can see that same information on the left there, over 19,000 new admissions, but trending slightly down by about 4.3%. Unfortunately, deaths are continuing to increase. This is something we are still sadly seeing with each surge. One day, if we can get to the point where hospitalization and death does not increase every time we have increases in cases, that would be great, but we are not there. And this is partly because of the underutilization of outpatient treatments like Paxlovid, which we know can significantly reduce the risk of bad outcomes. But looking here at weekly deaths, the week ending August 26th, that's the last week that we have complete data for, there were 959 deaths, and that was up 844 compared to the week before. And it looks like they've gone up even further after that, but those data are still incomplete. So we are sadly still over 3,000 deaths per month from COVID. Variant proportions haven't been updated, but overall, no news is good news here, and there's really nothing to report this week about variants, so let's hope it stays that way. So now I am going to talk about COVID-19 vaccine and long COVID. And I'm going to take some time to go through this systematic review and meta-analysis because I think it is the best evidence brought together in one place for us to take a look at and kind of wrap our arms around these questions. And mind you, we don't have definitive answers, but we certainly can walk through the evidence that we do have and see what we can glean from that. So remember that a meta-analysis combines the results of multiple studies that are essentially addressing the same research question. And so a good meta-analysis is going to, well, first of all, include studies that are actually capable of answering the question they're asking. That can be a downfall. We've seen that in some meta-analyses, and it's really important that we scrutinize these things in a number of ways. A good meta-analysis will describe the population. The intervention that they're investigating will be clear and consistent, and they'll describe a group they're comparing to and a specific outcome that they are looking for. And I'm going over this a little bit more today because there are poor quality meta-analyses out there, but when they're well done, they can be incredibly useful. There are a number of other things that go into making sure a meta-analysis is giving you meaningful results. And this meta-analysis that I'm going to go over today meets those criteria. And for those reasons, the results are quite useful. Now, if we had a big randomized control trial where we gave half of the group the vaccine and then withheld it from the other half and then waited to see who got long COVID, then we probably wouldn't need a meta-analysis. But we cannot do that kind of study. It is unethical to withhold vaccine and then wait to see how someone does, because we know too much now about the benefits of vaccination, particularly against severe outcomes. So that's just not a study that can be done. So instead, we're going to be observing differences in the population. And there are several ways to do that. And again, a meta-analysis will take the best of these, put them together, and give us a more complete picture than each one of the studies alone. So in that way, a properly done meta-analysis can add to our understanding more than each of the individual studies alone. So there have been studies that have clearly demonstrated that how severe your COVID infection is does play into your risk of ending up with long COVID. So there have been a few studies that have shown that people who are hospitalized and people who go to the ICU are several times more likely to get long COVID. Also, we've seen that those who require oxygen, those who go on a ventilator, they are more likely to have long-term effects as well. So since we know that vaccines do reduce those outcomes of hospitalization and ICU and ventilation and oxygen and all that, it is plausible that vaccinated patients will just have a lower incidence of long COVID because they have a lower chance of those severe outcomes. But we also know that how severe your COVID infection is not the only contributing factor to whether you will develop long COVID. And this is really important because so many people are getting COVID all the time. And the majority, thankfully, do not end up in the hospital or ICU. So at this point, we are clear that the largest numbers of people with COVID are actually people who had what we would call mild COVID in the first place. So yes, the percentage risk is higher if it's very severe, but at this point, with the sheer numbers, the majority of people with long COVID had mild infection in the first place. So we want to understand if the vaccines have an effect beyond just the fact that it's keeping you from going to the hospital or going to ICU. We want to know if the vaccine is sort of independently also reducing the risk of long COVID or not. So this analysis helps us to do that. So part of their process when they did the literature review is they did not include any preprint articles. So all of these articles had to have passed peer review, which is important. And not all meta-analysis do that. They also did not include any studies without original patient data. This is really important as well. They removed any duplication where studies might have been from the same cohort. And they also did a lot of work to synthesize the data and analyze it when it's all taken together. They were able to pull out each of the outcomes and assess the overall certainty of each outcome they were looking at. They initially identified 963 different articles, and they went through a process of removing the ones that didn't meet the criteria. And at the end of the day, they included 12 studies. So this meta-analysis was looking to understand two things. One, the effect of vaccination when you get it before you catch COVID on whether you then get long COVID. So vaccinating before you get COVID, does that reduce the risk of long COVID? And secondly, they were looking at the effects of vaccination for those who already have long COVID. So it's kind of like two analyses in one. So I'll go over each one separately. So first, looking at the effect of vaccination before getting COVID. The main outcome they were looking at was the incidence of long COVID. So out of all the people who got long COVID, what proportion was vaccinated versus what proportion was unvaccinated. So primary outcome is, did they get long COVID? Secondary outcomes were specific to the symptoms. So they looked specifically at persistent symptoms like fatigue or disorders of different organ systems like respiratory, cardiovascular, neurological, and so forth. So for this part of the study, they looked at 6 different studies that involved over 500,000 unvaccinated patients and over 84,000 vaccinated patients. So specifically a total of 536,291 unvaccinated patients and 84,603 vaccinated patients who received vaccination, then got a SARS-CoV-2 infection. And I won't go through all of the baseline characteristics in the study that were included, but just a couple of highlights. The studies were all looking at those 18 and up, and they did look at differences between no vaccine, one vaccine, and 2 vaccines. And then one of the studies looked at a 3rd vaccine. The follow-up duration after the acute COVID was 28 days to 6 months. So 28 days makes sense because that's when you can meet the definition of long COVID if your symptoms have gone on for at least 4 weeks. And if there were multiple follow-ups, then what they did in this analysis was take the later date or the longer time frame because they were really assessing the role of vaccination in preventing long-term effects. So that makes sense. So the range was 28 days to 6 months of follow-up after having had the COVID infection. And the 6 studies were from all over the world, including 2 from the United States, 2 from the UK, and 1 each from Turkey and Italy. And only one of the studies compared different types of vaccines, so they couldn't do a meta-analysis on that part, but I'll share the results of that as well. And what they were able to determine is that 2 doses of the COVID vaccine was associated with a lower frequency of long COVID compared to no vaccine. In fact, people who had 2 doses of the COVID vaccine were about 36% less likely to end up suffering from long COVID. So remember that this doesn't even consider the fact that people who are fully vaccinated are less likely to get COVID in the first place, right? We know it's not 100% by any stretch, but it does reduce the risk of getting COVID. But that doesn't even count that part of the benefit. This is actually about the people who got the vaccine, got COVID anyway, and then ended up suffering from long COVID. So a similar reduction was seen when you compared 2 vaccinations to 1, meaning that getting 2 vaccines really did significantly reduce the risk of long COVID compared to just 1 dose. When they looked at 1 dose compared to no doses, they did not see a significantly lower frequency of long COVID. So all of this suggests that the reduced risk of long COVID is really seen after 2 doses of the vaccine. So for this outcome, long COVID, 1 dose did not appear to be enough. I mentioned that one of the studies compared different vaccine types to each other. So this is not actually part of the meta-analysis, but that study individually showed that the mRNA vaccines were associated with a lower incidence of long COVID as compared with the AstraZeneca vaccine. That's not a vaccine that we have here in the United States, but basically they did not see any difference between the Pfizer and Moderna with respect to long COVID. And when they looked at specific symptoms, 2 doses of the vaccine corresponded to a 38% lower risk of persistent fatigue and a 50% reduced risk of pulmonary disorders. There were also some trends towards reduction in issues with other organ systems, but the certainty or the significance were not as high as the fatigue and pulmonary disorders. So the risk of long COVID overall was reduced with the two vaccines, and the risk of fatigue and pulmonary disorders was also reduced for those receiving two vaccines compared to the unvaccinated. And the second part of the study was investigating the effect of vaccination after SARS-CoV-2 infection and after someone already has long COVID. So they wanted to know, would the vaccine change the symptoms of long COVID? And they looked at another 6 observational studies that involved over 8,000 people with long COVID who received a vaccine after their COVID infection. So it was 8,199 patients with long COVID who received a vaccine after their SARS-CoV-2 infection. And in terms of baseline characteristics here, also looking at 18 and up, they looked at all vaccine types. The studies were from all over the world and included 2 studies from the UK and 1 each from Italy, Netherlands, France, and Japan. So we are looking at over 8,000 patients with long COVID who then got a COVID vaccine. And the median amount of time between getting COVID and then later getting the vaccine ranged from 146 days to 483 days. So from roughly close to 5 months to 16 months or a year and 4 months. So this is a fairly long duration, 5 months to 16 months between getting COVID and then later getting the vaccine. And the results that they found are pretty much all over the place. They didn't have any strong certainty or significance. This may speak to the fact that those that already have long COVID are experiencing different things that likely have different underlying causes of the long COVID. I've done kind of some deeper reviews on this in prior briefings, which I've linked in the post if you want to kind of have a refresher about long COVID and also the different reasons or mechanisms why we think people may be getting long COVID. So it does kind of stand to reason that any treatment or any intervention would need to be tailored to the different causes. So this is a topic for another day, but unfortunately what we saw in this analysis regarding getting vaccinated after long COVID is basically we don't have solid evidence one way or another. All the results we saw were low certainty or very low certainty. What they did observe was roughly 20% improved, 20% worsened, about 55% stayed the same. But again, they didn't even have moderate certainty here. There was nothing compelling or convincing about getting a vaccine for long COVID symptoms. So that's not about other reasons why we need to get the vaccine, but nothing was convincing about getting vaccinated for long COVID. One study did show that more than half of the worsening after vaccination got better within 3 to 7 days. So that's promising. Another showed that the worsening following vaccination was mostly from just regular anticipated vaccine effects like fever, chills, fatigue, and muscle and joint pain. So those are reassuring. Those weren't really part of the meta-analysis because those were in the individual studies, but all of this to say we have a lot to learn here. And of course, what we don't want is for anyone with long COVID to get another COVID infection. So the booster dose remains a very important consideration, even given all the uncertainty that I mentioned. And definitely anyone at risk of a bad outcome from COVID is more than likely going to be recommended to get the booster as well. And of course, anyone at risk for a poor outcome, we want to make sure that you have timely access to outpatient treatment also. So unfortunately, no evidence that the vaccine will be a treatment for long COVID, or at least not for everyone with long COVID, even though some people may have improvement of their symptoms. And I think this is an important area for study. What was going on with that percentage of people who had improvement or that percentage of people who had worsening? There could be some clues there. So I'm sure that there's different studies going on, but right now we still have a lot to learn. And as far as looking at the booster dose, we don't have a bunch of information about this. One of the studies in the meta-analysis, the one out of Italy, did look at a third dose among healthcare workers who didn't require hospitalization. And they saw that 3 doses of the vaccine did provide greater protection against long COVID than 2 doses. So we definitely need more studies to understand all of this, but all the signs seem to be pointing in the same direction, which is that whether it's a mild or a severe initial infection with COVID, 2 doses of vaccination do reduce the risk of long COVID. One other last thing I wanted to note I thought was interesting. We always try to understand, are there other variables that could be affecting our outcomes? So one thing we would want to know here is, are there differences between the people who only get 1 dose between versus the people who get 2 doses? And there actually have been a few studies that show that people who got the 2 doses were people who were actually more likely to have pre-existing conditions than those who got no vaccine or even those who got 1 dose. And we know that some of those with pre-existing conditions like asthma or diabetes or immunosuppressive conditions, those individuals are actually at increased risk of long COVID. So the findings in this meta-analysis that people who got 2 doses, and again, in general, these are people who are more likely to have pre-existing comorbidities, but they still ended up having a significantly lower incidence of long COVID. So I think this just further drives home the point that vaccines appear to independently be reducing the risk of long COVID. Still have a lot to learn, but with all of this information, the authors conclude that vaccination before SARS-CoV-2 infection can be recommended to reduce long COVID. So in summary, we're seeing some possibly early signs of coming down from this late summer, early fall wave with slight trending down of percent positivity. Our ED visits are continuing to come down. And now finally, for the first time in months, hospitalizations appear to be starting to come down. Hopefully we will see deaths come down next. The best tools we have as far as preventing those bad outcomes remain vaccine and treatment and layered mitigations. We now have the monovalent mRNA boosters approved. These are tuned to the current variants and they are becoming available now. Just remember that with the commercialization of the pandemic response, the federal COVID vaccine program has ended. So we're all shifting the way that we get COVID vaccines, and some clinics and offices are undoubtedly deciding whether they will be carrying them and for whom or who they need to refer people to. The Bridge Access Program is providing no-cost vaccines for uninsured and underinsured, but supplies and locations are definitely limited compared to our prior vaccine rollouts. So we're all having to update our systems according to the criteria of whoever's paying for the vaccine. For example, at Roots, where we've never required insurance information, we are now required to collect that information because that will determine whether you could access the Bridge Access Program vaccine or the commercial supply of the vaccine. But everyone will have the vaccine covered. All of this will settle out. There will definitely be challenges along the way, but especially for those in the higher risk categories and you haven't had COVID in 3 months or a booster in 2 months, the recommendation is that you get your monovalent as soon as you can access it and get whichever brand you can access the soonest. In the meantime, let's keep up our best practices to prevent the spread of COVID and prevent outbreaks. No one layer is foolproof, so we want to implement layers of protection. Stay up to date on vaccination. Wear a high quality filtration mask like an N95, KN95, or a KF94 or better, especially indoors with others. Monitor and improve indoor ventilation and filtration, and whenever possible, gather outside. It is almost always safer than indoors. And even if you've had COVID once, you should try to avoid getting it a second time. If you had it twice, try to avoid getting it a third time, and so on. There is mounting evidence of cumulative effects of repeat infection. There does not seem to be any limit to the number of times you can catch COVID. And following COVID, we are seeing increased risks of impacts on almost any organ system. We're seeing new onset diabetes, blood clots, heart attack, stroke, memory issues, worsening asthma, and some subset of people, we can't predict who. This could happen after the first infection, but it might happen after the second or after the third. Catching COVID once and doing fine is not a guarantee about the next time. Sometimes repeat infection can be more severe even in the acute phase. Sometimes it's worse in the longer term. And every infection is a new opportunity, perhaps even a compounded opportunity for long COVID and post-COVID impacts. If you don't feel well, please stay home and rest, get tested so you can make an appropriate plan to not spread what you've got to others. If you're someone who should be treated if you catch COVID, then you should know that in advance and you should have a treatment plan. These are the outpatient treatments for SARS-CoV-2, and you have to start them as soon as possible. The sooner, the better. Treatment can reduce the risk of hospitalization or death by about 80% if you start it on time. Starting treatment on time means testing on time, so know in advance where you can get tested, and all of this is shifting, so stay up on your resources. And not only should you have a treatment plan, but you should have a caregiving plan for anyone who you take care of and maybe for who's going to be taking care of you. Since we should do what we can to prevent household spread, a plan for isolating and ensuring children and anyone else who needs caregiving should be made in advance. And if you do come up positive for COVID, please test negative before you go back around others. In general, when it comes to our antigen test, enough virus to detect is enough to infect. If you don't have a primary care provider, please get one. Know how to reach them before you need them. Remember to eat a balanced diet and avoid those sugary drinks. Consider a multivitamin supplement and perhaps vitamin D. Get some regular physical activity unless you're sick. In that case, please get your rest. Get your blood pressure checked, your baseline labs checked, like sugar, cholesterol, vitamin D. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.